Welcome to liver pathology. There is a lot of information, so I am going to speak very quickly. There are 209 slides in this presentation. This is about a 2-hour presentation. We will be going over basic information, pathology, other findings, and liver function. Why do we want to know all of this pathology? We're not going to be making any diagnosis, right? We don't have to look at pictures and give a differential diagnosis to our radiologist, or do we? Sometimes we do, actually. Sometimes a radiologist wants to know what we think it is that we're looking at, and they'll believe us. Is when you get really good at scanning ultrasound and your radiologist learns to trust you, if they're looking at something and they're not really sure what it is that they're seeing, they'll call you up and they'll say, hey, what do you think that was? And then you can tell them. Additionally, there's more reasons why we need to know all of this pathology. We have to check the indications on exam orders to make sure that the exam matches the clinical concern. If you get an order and it says that the doctor is concerned that this patient has a DVT due to leg swelling, but the exam is an ABI, which is going to check for their arterial blood flow, first of all, that's not going to answer the question if the person has a DVT. Secondly, if the person has a potential DVT, the last thing we want to do is put blood pressure cuffs on their legs and squeeze, because that's going to dislodge it and give them a PE while they're on our bed. So, unfortunately, indications not matching exam orders happens all day long, every day. So we need to know. Also, we'll be implementing different scanning techniques depending on the presenting pathology. For example, with cirrhosis, we can scan a liver with a linear probe to take a look at that surface nodularity. Have you scanned a liver yet with a linear probe? Probably not. Did you even think that that would be something that you'd end up doing? Probably not, but there you go, now you know. We have to know where to look for different signs of pathology. So, for example, if we know that someone has cirrhosis, and then what we do is we do quite a few different things, but one of the things is we'll scan that ligamentum teres, that round ligament, and we'll put some color on it. I recommend power Doppler, and I recommend scanning through it, long and trans, and see if that area has a recanalized paraumbilical vein, because the radiologists and the providers need to know if that's developed. We have to know how to properly document specific types of pathology. We have to be able to show our radiologists adequate information so they can make appropriate recommendations. If you read a RAD report, it's going to list the findings, and then it's going to say what the radiologist thinks is going on. They're the ones that give a differential diagnosis, and then based off of that, they'll give recommendations, and their recommendations might be something like repeat ultrasound in 6 months, see if anything's changed, if the area grows. It might be do some additional imaging, like try a CT or a CTA or an MRI or something like that. It could be recommend biopsy. So the radiologist is going to make their recommendations based off of what you show them. So, for example, if you're looking at something in the liver and you're thinking, hey, this might be focal nodular hyperplasia, or this might be an adenoma, well, one of them is going to require surgical resection and the other one doesn't. So the radiologist is probably going to recommend a biopsy of that area. But what if you set your color flow correctly, so that way you can really analyze the color of that area? And what if you show a spoke sign? Then potentially you might save that patient a biopsy if you can show that it's focal nodular hyperplasia. Additionally, at the end of the day, we're curious individuals, right? And we probably care about our patients, at least I hope that we do, at least some of the patients. And oftentimes you're going to walk away from a scan and you're going to wonder, what was that? And what does that mean for the patient? Is that a great big cancer that I just saw? Is there a certain size limit under which they can just resect that area if it's sassy? what's going to happen to this person? This person was so nice to me. They thanked me a million times. And if it's something bad, I'm going to feel really bad. And maybe it's not bad. Maybe it's just a hemangioma and you don't need to worry. So if you know, then you'll know. Here's all the liver pathology that you'll need to know for your upcoming exam. I strongly recommend that you memorize this list. If you're able to write this list out at the beginning of your exam, it's going to help give you some focus. It's going to help you stay calm. If you're asked any question about pathology, you're going to know that it pertains to something on this list, and being able to see your multiple choices is going to help you be able to more easily narrow things down. It's going to make this whole exam feel a lot less overwhelming. This is one of my tricks that I've used for a very long time when it comes to test taking. Memorize your outline. One of the tricks that I use in order to help me memorize it for the test is I memorize how many categories do I have and then how many items under each category is there. So for example, we have 5 categories. 1 is diffuse, 2 infections, 3 focal, 4 benign, 5 malignant. Those categories are going to start looking real familiar from this test onward, okay? How many then in each category are there? We've got 5, 6. I'm not repeating hepatitis just to keep things simple, okay? 2, 5, 4. So there's 5 things in under diffuse that we need to know, and so on and so forth, right? So first, all I do is I write those numbers out. 1, 2, 3, 4, 5, and then under 1, 1, 2, 3, 4, 5. Under 2, 1 through 6. Under 3, 1, 2. You get the point. And then I work on filling it all in. And I write that list over and over and over, repetition until I've got it down. When I can write that list just from memory, then I'm set and ready to go. It's really worth its weight in gold. Strongly recommend that you do it. The next step in memorizing my outline is to use the first letter of each area in a mnemonic device. So for example, for the titles of the categories, diffuse, infections, focal, benign, and malignant, we can use a mnemonic device to remember those first letters for our outline, detecting irregular fibrosis by monitoring. And then, for example, for the first category of diffuse diseases, we can use a mnemonic device, fatty hepatocytes cause great harm, and so on and so forth. If you don't like these mnemonic devices that I have written here, these little sentences, you are welcome to use vondi.com for free to create your own. All right, some basics. Normal length of the liver is about 15 to 17 centimeters. Anything bigger than the 15 centimeters is considered hepatomegaly. That doesn't make sense, right? Well, that measurement is the superior to inferior, which is cranial to caudal, and I'll show you that picture next. But you need to know hepatomegaly is anything greater than 15 centimeters. We'll also see additional signs of hepatomegaly, not just the length, right? It's going to extend beyond the right kidney, and it's also going to have a more rounded contour to it. Other things we need to know is that the liver is an intraperitoneal organ, except for the bare area. It's covered in Glisson's capsule, which is that visceral peritoneum. Other organs are compared to the liver parenchyma. That's an important thing to know. So for example, if that's a normal looking liver and then that pancreas by it looks like it's hyperechoic to that liver, well, that pancreas might have fatty infiltration itself, or maybe there's some type of pancreatitis going on. Maybe that's sick. So we need to know that. So I don't know if while you've been scanning, you've noticed that some of your peers might have a liver that seems to be measuring greater than that 15 centimeters. Well, that's because we're measuring that maximum dimension. And when they're talking about the greater than 15 centimeters, they're talking about that craniocaudal dimension. And that's typically used more so with CT. So one normal variant that you've heard of is Rydell's lobe. That's where the liver will appear to extend beyond that right kidney's inferior pole, but it's just a normal variant. So Rydell's lobe and hepatomegaly, fatty infiltrated, they're going to look different, okay? So Rydell's lobe is going to maintain kind of a sharp corner, and then the hepatomegaly, the bigger livers are going to have a more rounded appearance as it extends beyond that inferior pole of that right kidney. So another normal variant, this one's not in your notes, but I promise you'll want to know it. It's called beaver tail. You know how when you're scanning left liver long and you're scanning laterally, you're going all the way out for your survey? Well, for this anomaly, you're not going to make it all the way out. It's going to look more like the right lobe. You're going to end up looking at spleen and you're going to wonder what's going on. And I promise you that the first time that you scan it, it's mind bending. It's kind of hard. This is what that beaver tail looks like. So the area in between the arrows is the liver, and then S marks the spleen, and then that's the left kidney over there. All right, now into the liver pathology. So the clinical symptoms are going to be related to GI things and then also some vascular things because of the serum proteins that the liver is supposed to be making, but if it's sick, it can't make them. So if you're looking at this list here, you can see the high blood pressure, internal bleeding of veins, the different blood vessels, swelling of the lower legs, bruising easily, low platelet counts, things like that are going to be affected by, well, the development of the platelets. The heparin, albumin, those things help keep the blood from not clotting too quickly and then also still clotting when it's supposed to clot. And then also maintaining blood volume. And then the GI things as well, the nausea, the diarrhea. Nausea and diarrhea are a common indication for right upper quadrant scans. And then loss of appetite, also fatigue. If you see jaundice on someone, you're going to know that there's some gallbladder / liver issues going on. So in your notes, you have 7 clinical signs listed. Anorexia, meaning that people don't want to eat because they don't feel good, right? Not feeling good, abdomen discomfort. So pain is another indication that right upper quadrant pain is an indication that you'll see very often, especially through the ER for that right upper quadrant scan. Abnormal LFTs, another indication on those exams that you're going to see all the time. That one's typically going to be more so for your outpatients. Fatigue and weakness, fever, especially with viral hepatitis, jaundice suggests biliary obstruction, and then enlarged liver on physical exam. Sometimes a clinician can, well, when they're checking you for your annual exam and they're palpating on your right upper quadrant, they're literally feeling your liver. Or if they're palpating on your left upper quadrant, they're feeling your spleen. So sometimes one or the other will feel big, and if it's the liver, we'll be scanning that liver. Our first group of pathology falls under diffuse disease. All right, there are 5 diffuse diseases that you need to know. 1, fatty infiltration. You're going to see this all day, every day. 2, hepatitis. 3, cirrhosis. You'll also be seeing this often. 4, glycogen storage disease. And 5, hemochromatosis. So diffuse hepatocellular disease affects the hepatocytes and therefore interferes with liver function. The hepatocyte is a parenchymal liver cell that performs all of the functions attributed to the liver. They are considered glandular, which will be important later when we talk about liver cell adenoma. Diffuse disease is measured through the series of liver function tests. The hepatic enzyme levels are elevated with cell necrosis. So when they check the blood, the enzyme levels are increased because the cells are breaking apart and all of those enzymes are coming out. The first diffuse disease is fatty infiltration. The continuum of the stages of liver damage. You're going to know this forwards and backwards because you're going to see this all the time. First, a person has a healthy liver. Then, through diet, lack of exercise, drinking, then that liver starts to deposit too much fat within itself. That's what it does, is it stores fat, right? But there's too much. Hepatic steatosis. Fat, osis, too much. Okay? That part is reversible. How would that be reversible? Through diet and exercise. As long as the cause is already poor diet. There are other causes of fatty liver, which we'll talk about, but typically what's causing fatty liver is too much fat intake, okay? After a little while, there's too much fat in that liver, and then it starts to get inflamed. It gets irritated. At that point, now it's called steatohepatitis, right? Osis is too much, itis is inflammation. It's still reversible. A person still has a chance of taking away, eliminating whatever factor it is that's causing that fatty liver and putting their liver back towards healthy, okay? However, if they progress into liver cirrhosis, at that point, the condition is irreversible. And if they've been making poor life choices and that's what led them to cirrhosis, well, now they have to make better life choices or else they'll die. So that diet and that abstaining from alcohol that they didn't want to do prior to cirrhosis, they're going to start doing, or else they're going to be very, very miserable. What are the causes of fatty liver? Like I had mentioned, obesity and excessive alcohol intake are the two most common causes of fatty liver. There are other causes, for example, pregnancy. So hopefully after the pregnancy, that will reverse itself. Total parenteral hyperalimentation basically means tube feeding, okay? That's what that is. Other things can cause fatty liver, glycogen storage disease. We'll talk more about that, but really the name is what is happening, right? It's storing glycogen, so it's storing fat in the liver. There's also pharmaceuticals. Certain medications, chronic illnesses can cause fatty liver. Cystic fibrosis, a person's born with that. They can't control that. So with that one, things really aren't their fault. Diabetes, well, if you're ever taking an exam, including board exams, and the question is what's a cause of any type of pathology and diabetes is listed, go ahead and answer that one because it's pretty much the cause of so many things that can go wrong in the body. Non-alcoholic fatty liver is fatty liver which wasn't caused by alcohol. For example, someone with cystic fibrosis who has a fatty liver will be diagnosed then with a non-alcoholic fatty liver disease, especially if they haven't been consuming excess quantities of alcohol. When you scan a liver and you suspect fatty liver infiltration, you will comment on a few different things. You'll say, for example, decreased penetration. You'll say that the liver is markedly hyperechoic to the kidney. You can say that it has a rounded appearance. You can say that it appears enlarged. There are different grades of severity of fatty liver. You'll probably need to know these for upcoming tests, board exam, life out in the field, etc. Okay, so it seems kind of obvious, like, oh, well, there's mild, moderate, severe. You need to know that, yes, there's mild, moderate, severe, and I also strongly recommend knowing exactly what each one of those means, okay? So for mild, there's minimal diffuse increase in hepatic echogenicity with normal visualization of the diaphragm and intrahepatic vascular borders. So what we're looking at is the level of echogenicity, and we're looking at how well we can see penetration-wise, see that posterior diaphragm, and we're looking to see how well we can see all those vessels. At moderate, we have an increased echogenicity with slightly impaired visualization of the diaphragm and intrahepatic vascular borders. So maybe you're dropping your frequency a touch. You can still find those vessels okay. You can still drop your color in those hepatic veins. You can get through your scan okay. At severe, there's a significant increase in echogenicity of the liver parenchyma, decreased penetration of the posterior segment of the right lobe of the liver, and decreased to poor visualization of the diaphragm and hepatic vessels. This is the I can't see squat scan. You're dropping your frequency all the way down, and maybe you're kind of seeing that diaphragm and that posterior right lobe, but maybe you're not seeing it very well. You're trying to find those vessels so that you can take a waveform of the hepatic vein, and you're really struggling to even find it. And believe it or not, that yes, that happens, and it happens with way too much frequency. Fatty infiltration, sonographically, we're seeing 3 things. 1, that liver's enlarged. 2, it's hyperechoic to the right kidney. 3, it's increased attenuation. Here's a nice comparative set of images where there's normal, mild, moderate, and severe fatty infiltration. Here's another really good example of grading for fatty infiltration. You've got normal, mild, moderate, severe. Look at how much you can't see that posterior border of severe. Or is that diaphragm? I'm not sure. Is there anything hiding in that right posterior lobe? Oh, by the way, where do we find the majority of our pathology? In that right lobe. Can I see that right lobe? No. Do they have pathology in there? I don't know. Look at the difference in those vessels. Like itty bitty dots, itty bitty lines. It's like they're compressed together. You can hardly see them the more severe that fatty infiltration becomes. When you see that class 3 fatty liver, that severe fatty liver, you want to tell your patient to eat healthier and avoid alcohol because you know that they have a chance to reverse hepatic steatosis. They have a chance to reverse that fatty liver, but they cannot reverse what comes next. What is it that comes next? After fatty liver comes cirrhosis. Now, any of the diffuse diseases that we'll be learning about can lead to cirrhosis. All of them that are listed, well, I'd say 5, but cirrhosis is one of the 5 that are listed, can become cirrhosis, okay? But after fatty liver can come cirrhosis. With cirrhosis is a whole different entity, is a whole different kind of beast, okay? With cirrhosis, that patient can become a weekly paracentesis patient. That means that they're going to fill with ascites, they're going to fill with fluid. That's very uncomfortable. It's heavy. It makes it harder for the patient to be able to breathe. They've got this large rounded belly, and then they have to come in and they have to get stabbed and poked and prodded in order to be drained. And before being poked and prodded, just for that interventional procedure to have that paracentesis, they have to have their blood drawn to make sure that they will actually clot. But also remember, their blood's not making those enzymes to make sure that they're clotting correctly. So that can be a whole other slew of issues. Now they really have to be on a very strict diet. They can't consume as much sodium or else they're going to have ascites. So that's a really bland diet. They really need to not drink anymore because their liver won't be able to handle it at all. They're going to be on a liver transplant list. I've had patients for a very long time coming in for paras and not getting their transplant because it's a long list. They might need a TIPS procedure, which is an interventional procedure to reroute the blood directly from the portal vein through a hepatic vein. They might get hepatic encephalopathy. You'll probably see that. I've seen it a few times. That patient will be out of their mind. They don't know what's going on. They're in and out of consciousness, depending on how severe. It might be a very complicated, difficult, challenging scan for you, okay? Cirrhosis can then lead to cancer. It can lead to hepatic cellular carcinoma, and it can lead to death. Cirrhosis, no bueno. Here's beautiful sonographic images representing the progression from normal to fatty to cirrhotic livers. This is from Sonographic Tendencies, so thanks Henry Stacks. So sometimes fatty infiltration doesn't want to actually be diffuse. Sometimes it wants to focally infiltrate, and sometimes it wants to infiltrate everywhere except a focal spot. So when it's infiltrating in one particular location or in a few locations, but in a less diffuse pattern, it's called focal fatty infiltration. And when it's infiltrating all but focal areas, then it's hypoechoic, and it's going to be focal fatty sparing. So focal fatty infiltration is going to be these little hyperechoic areas. I probably don't see focal fatty infiltration as often as we see focal fatty sparing. But with focal fatty infiltration, how are we going to know that that's what that is versus a discrete lesion? Well, does it have discrete borders? Does it have a vessel that's coursing through it? Is it infiltrating a vessel? Is it pushing up against a vessel? Focal fatty infiltration is just going to put itself into the liver parenchyma, and it's not really going to disturb the surrounding architecture very much. Focal fatty sparing, we see this all day, every day. Oftentimes, you can get through your whole liver protocol, and then you get to your gallbladder protocol, and you really zoom in up on that gallbladder, and you notice, oh, look, there's this little dark spot that's hanging out right by the gallbladder, especially right by that gallbladder neck, sometimes right along that gallbladder body, and you're like, I'm going to go back and add these pictures to the liver, because this is part of liver, and it's focal fatty sparing. Typically, like I said, it's going to be by the gallbladder. It has a very apparent look. You'll get used to seeing it. We don't measure the area. We'll show it in long and trans, and we'll put color on it, and then we'll even label our picture something like FFS question mark. And yes, that can also stand for something else. And sometimes that's what I'm thinking of myself because I maybe missed it when I was scanning the liver, or now I've just got extra pictures that I have to take to show this. But focal fatty sparing. All right, so again, why do we need to know pathology? Because we need to know how to scan it, whatever it is that we're looking at, right? So if we see a focal hyperechoic area in the liver, then what do we look for to help us narrow our differential diagnosis? If that area surrounds but does not distort the vessels, then it's likely focal fatty infiltration versus a tumor. So as already mentioned, if we see a focal hypoechoic area in the liver, then we can look for a couple different things to help us narrow our differential diagnosis. If the area surrounds but does not distort the vessels, then it's likely focal fatty sparing versus a tumor, just like focal fatty infiltration. Also, focal fatty sparing is most commonly found anterior to the gallbladder or portal vein and in the medial left lobe anterior to the porta hepatis, often seen best when imaging the gallbladder versus the liver sweep. But you should try to not miss it during your liver sweep as well. All right, real life scenario here. Your ultrasound abdomen limited patient is coughing, but says she has a residual month-long cough from an old upper respiratory infection, and she is no longer contagious. She is here for elevated LFTs. What do you do? Do you turn her away because COVID? Or do you go ahead and scan her? Let's say you just go ahead and scan her, and to your surprise, her liver looks totally normal. What is going on? Why would she have elevated LFTs, but then her liver would be normal? Maybe she has hepatitis As we'll see in the next slide, hepatitis can occur from infections elsewhere in the body. So let's get into it. Let's get into diffuse disease hepatitis. Hepatitis is the general name for inflammatory and infectious disease of the liver. Hepat means liver, itis means inflammation. Disease may result from a local infection in the liver, such as viral hepatitis, from an infection elsewhere in the body, for example, infectious mononucleosis, amoebiasis, or from chemical or drug toxicity. Mild inflammation impairs hepatocyte function, whereas more severe inflammation and necrosis may lead to obstruction of blood and bile flow in the liver and impaired liver cell function. Your patient presents with the following clinical symptoms: loss of appetite, nausea, vomiting, fatigue, and jaundice. Your patient is a fellow sonographer. What's up, friend? Your patient says they were guiding a paracentesis and the radiologist accidentally stuck them with a used needle. Uh-oh, your heart sinks. What are you concerned the diagnosis might be? We're concerned that this patient might now have hepatitis B. Why? Because if they were guiding a paracentesis, then the patient had ascites, so they very well could have had cirrhosis. So that cirrhosis could have been caused by hepatitis B, and hepatitis B is transferred via blood and other bodily fluids. Viral hepatitis specifically is considered to result from infection by a group of viruses that specifically target the hepatocytes. There are quite a few different types of viral hepatitis. The A's, the B's, the C's, the D's, the list goes on. The most common viral hepatitis is B by a lot. It's spread via contact with infected body fluids. So there's both acute and chronic viral hepatitis. Chronic hepatitis is when it lasts for longer than 6 months, and that's typically with just about anything. If something lasts longer than 6 months, now it's deemed chronic. Acute, you're going to have that nausea and vomiting and that right upper quadrant pain. Bilirubin's going to be up. That means jaundice, pruritus, that's that itchiness. The dark urine, clay-colored stools. And then hepatomegaly. That's probably going to be important to know. Under chronic, sometimes they're asymptomatic. Sometimes they'll have fever, fatigue, loss of appetite. And then there can be extrahepatic symptoms like joint pain, the arthralgias, and then also skin rashes as well. So oftentimes with any kind of liver disease, we'll see a bunch of elevated liver function tests, elevated LFTs. We'll see an increase in AST, ALT. We'll often see an increase in bilirubin, sometimes if the gallbladder is affected even. With viral hepatitis, we'll see leukopenia. Penia meaning less, right? So penia reminds me of pequeña, which means small. And leukopenia is common with those viral infections. So, hey, it's a viral hepatitis, leukopenia. So that's going to be something that's a little bit different and noteworthy for hepatitis. Without complications, clinical recovery from acute hepatitis usually occurs within 4 months. Complications of hepatitis can involve damage to the liver and may range from mild disease to massive necrosis and liver failure. Pathologic changes include the following: liver cell injury, swelling of the hepatocytes, and hepatocyte degeneration, which may lead to cell necrosis, reticuloendothelial and lymphocytic response with the Kupffer cells enlarging. As a reminder, Kupffer cells are phagocytic cells which are involved in the breakdown of red blood cells. We're going to talk about Kupffer cells again when we talk about focal nodular hyperplasia. And then regeneration. We'll also talk about death and regeneration of liver cells when we talk about cirrhosis. Sonographic characteristics of acute hepatitis. We have starry night sign. The liver texture may appear normal, or portal vein borders may be more prominent than usual because they might be in contrast to a liver parenchyma that is slightly more hypoechoic than normal. So they'll appear like bright stars, and the liver is going to appear like a night sky. So a little mnemonic is if you're with a cute person, then maybe you want to lie down and look up at the starry night sky. Whenever you see a sign that is related to ultrasound, I strongly recommend that you memorize it. It's probably going to be asked of you at some point, either an exam or a board exam, somewhere, okay? So acute hepatitis, starry night sign. Attenuation may be present. Hepatosplenomegaly is present. We see hepatosplenomegaly only with 3 of the conditions listed in our liver pathology notes. We see it here with acute hepatitis. We'll see it in early cirrhosis, and we can also see it in what I like to call small cirrhosis, the schistosomiasis. So we'll touch on those later. And then gallbladder wall is thickened. So next chapter, you're going to learn all about biliary system. With gallbladder wall thickening, oftentimes it's caused by stones. It's caused by those gallstones. So it's calculus gallbladder wall thickening or cholecystitis. But sometimes there's acalculous cholecystitis. There are other things that can cause gallbladder wall thickening aside from the common stones, and acute hepatitis right here is one of those things. So here we see that hepatomegaly, and if we were to look at the spleen, we would see the splenomegaly. We see that starry night sign, and then we see that gallbladder wall thickening, and I don't see any stones in there. Chronic hepatitis. So this is now when hepatitis has extended beyond that 6 months. Causes can be viral or can also be metabolic, autoimmune, or drug-induced. Chronic active hepatitis is defined as inflammation of the liver continuing without improvement for at least 6 months, with the histological findings of round cell infiltration of the portal tracts and moderate or severe piecemeal necrosis of liver cells extending outwards into the parenchyma. That chronic active hepatitis usually progresses to cirrhosis and liver failure. There's also chronic persistent hepatitis, which is a benign self-limiting process. That sounds a little counterintuitive, so let's just pause on that for a moment. Chronic persistent hepatitis is self-limiting. Persistent, self-limiting. Chronic active can progress to cirrhosis. Okay? Persistent, self-limiting, active, cirrhosis. So patient symptoms may include nausea, anorexia, weight loss, tremors, jaundice, dark urine, fatigue, and varicosities. So what does chronic hepatitis look like on ultrasound? Well, it's different than acute. The fibrosis may be evident, which may produce soft shadowing posteriorly. I'll show you what that looks like. The liver does not increase in size with chronic hepatitis. So acute hepatitis, hepatomegaly. By the time we get to chronic, now it's not so big anymore. It's like the swelling's gone down. The liver parenchyma is coarse. We'll see that with cirrhosis, with decreased brightness of the portal triads. So we lose that starry night sign. The degree of attenuation is not as great as is seen in fatty infiltration. Okay, but we're still going to possibly see that soft shadowing. So it's going to be kind of similar, but it's going to be different, and I'll show you that. So here are a few ultrasound images of chronic hepatitis. The one on the furthest right looks pretty normal actually. The other two, you can really see that soft posterior shadowing. It's almost like those shadows are vertical stripes versus a horizontal sweep of a shadow that you would see in fatty liver. And you can still see the diaphragm. Remember, as the degree of severity of fatty infiltration increases, then visualization of that diaphragm decreases, right? So I'll show you a comparative right here. So here's the difference between fatty liver and chronic hepatitis. That chronic hepatitis, like I said, those shadows are kind of vertically lying through that picture, whereas the shadowing on that fatty liver, it's like someone took half of that picture and just smudged dark ink over the top of it, right? Also, that diaphragm, look at how dark it is back there. It's like you're trying to see it through a fog versus that chronic hepatitis, that diaphragm back there, it looks real bright yet. How do we know sonographically when acute hepatitis has become chronic? They pretty much look like opposites. So acute is going to be hypoechoic and big, tall, dark, handsome. Chronic is going to be hyperechoic and small. Acute will have those hyperechoic portal vein walls. They're going to be in contrast to that hypoechoic background. Chronic will have decreased echogenicity of portal vein walls in contrast to the rest of the liver. Acute will have a thickened gallbladder wall. Chronic can have coarse texture, kind of like it's heading to cirrhosis. Acute, we get that starry night sign, and chronic, we get that soft shadowing. The next diffuse disease for us to talk about in detail is cirrhosis. Diffuse disease cirrhosis. So cirrhosis is chronic degenerative disease of the liver. The lobes are covered with fibrous tissue. So we have that fibrosis. That parenchyma degenerates. And then the lobules are infiltrated with fat. So the essential feature is simultaneous parenchymal necrosis, regeneration, and diffuse fibrosis, resulting in a disorganization of lobular architecture. Cirrhosis pathophysiology. So pathophysiology explains how that pathology happens, like what's going on that cellular level. If you get really curious about a pathology and you're wanting to know why it happens, why someone develops that condition, Google that pathology with pathophysiology, that term right there, and you'll probably find some, at least I think, really fascinating information. Now, some of this slide is going to be repetitive from the past slide, and that's because this is important, and I'm trying to really help you understand it, okay? So cirrhosis is a late stage of hepatic fibrosis that has resulted in widespread distortion of normal hepatic architecture. So fibrosis is that scarring, right? It's adding in fibrotic tissue. Cirrhosis is characterized by regenerative nodules surrounded by dense fibrotic tissue. So it's scarring and regenerating. There's two primary ingredients, hepatic fibrosis and regenerating liver cells. So in response to injury and loss, growth regulators induce hepatocellular hyperplasia, that overgrowth, producing regenerating nodules, and also arterial growth, angiogenesis. So genesis means new, angio means vessels. We have the blood vessels and we have lymph vessels as well. So in summary, what are the three major pathologic mechanisms that create cirrhosis? 1, cell death. 2, fibrosis. 3, regeneration. So the liver's trying to regenerate. It's trying to fix itself. It's trying to return back to healthy, like in that prior picture on that prior slide. But it's stuck in these fibrotic nodules. Okay, so it's not going to just fix itself. Cirrhosis may be both chronic and progressive, with liver cell failure and portal hypertension in the end stage. The scarring is irreversible. There's two kinds of cirrhosis. There's micronodular, which is most commonly the result of chronic alcohol abuse. So micronodular alcohol. Macronodular cirrhosis is typically caused by chronic viral hepatitis or other infection. Now, there are also other causes of cirrhosis, just like there are other causes of fatty infiltration. Some other things that can cause cirrhosis are biliary cirrhosis, Wilson's disease, primary sclerosing cholangitis, and hemochromatosis. And we'll be talking about hemochromatosis too. What is the most common cause of cirrhosis in the Western Hemisphere? Alcohol. ETOH is in the notes, means alcohol, just to make sure that we're on the same page with that. What other causes are there? Well, I just talked about some at the end of the other page, but again, obesity, hepatitis, hemochromatosis, biliary cirrhosis, Wilson's disease, primary sclerosing cholangitis. On the left, we have alcoholic cirrhosis with high fat content, that micronodular, and on the right, we have macronodular cirrhosis, viral infection. Biliary cirrhosis and hemochromatosis can also be micronodular. Also, micronodular can advance to macronodular cirrhosis sometimes too. And depending on where you look for measurements, our notes say micronodular is under 1 centimeter. Other places have different numbers, but just remember for now, 1 centimeter for micronodular. Early stages of cirrhosis are going to look a lot like fatty infiltration. You're going to have hepatomegaly and decreased vasculature. Both of these images are already starting to show some ascites. We might not see that with early stages cirrhosis. These images here show the ascites. So C is showing some fluid there in Morrison's pouch, and then D is showing a whole lot of fluid there, and then the more echogenic area is bowel. All of that above it is all the ascites. That's all fluid. And then B looks like a post-paracentesis picture. We're not seeing the fluid anymore. So fluid in the peritoneal cavity, whether it's ascites or blood, like a hematoma from trauma, collects in the most dependent area of the abdomen. And that's all that we say in radiology when we talk about dependent. We just say dependent. So what does dependent mean? They mean gravity dependent. Just kind of leave the word gravity out. So depending on how that patient is positioned, the fluid's going to move into that location, wherever the area that is closer to the ground is. While we're doing paracentesis procedures, we'll oftentimes roll that patient and kind of sit them up or roll them over toward where the draining catheter is to help get all of that fluid into that dependent location and get that fluid out. This excerpt is from ACR's practice parameter for ultrasound of the abdomen and retroperitoneum. Specifically, they're talking about liver and that the liver surface may be imaged with a high-frequency transducer to evaluate for surface nodularity in patients at risk for cirrhosis. So ACR is American College of Radiology, and different facilities will choose to be accredited by ACR so that they can receive like Medicare, Medicaid funding, things like that. So for example, when a hospital is up for ACR accreditation renewal, they'll submit different scans that they've completed, and then the ACR accrediting body will review those images and make sure that they meet the requirements. Also, just like to point out on here too that the standards or requirements talk about written request for the examination. So it's going to be specific signs and symptoms. Like I was telling you, we have to check the indications on orders and make sure that they're accurate. And part of that is through ACR accreditation. So use a linear probe to assess nodularity in cirrhosis. There you go. And here you go. Here are two ultrasound images of liver surface as scanned by a linear probe to really zoom in on and look at the nodularity there of that liver with cirrhosis. All right, I'm going to get a little bit more in depth with ascites because you're going to be seeing it often. You're going to be working with it. You're going to be not performing. We don't actually perform, but we do guide paracentesis procedures, okay? So ascites, in the setting of portal hypertension, backflow and stasis of vasodilatory substances begin to accumulate. This causes splanchnic vasodilation. Okay, splanchnic means organs, viscera of especially the abdomen. Okay, so splanchnic vasodilation with resultant hypoperfusion of the renal system. This activates the RAS system so that renin-angiotensin, I don't know if you remember from anatomy and physiology, but leading to aggressive fluid retention. So that RAS system is when the kidneys are quote unquote evaluating the blood as it passes through and determining how much urine to make out of that blood and helping with blood volume, right? So basically, there's portal hypertension. There's a backflow and stasis of the vasodilatory substances that causes hypoperfusion of the renal system, which then causes aggressive fluid retention. And so that's part of why patients who have cirrhosis, if they don't want to accumulate too much ascites, they can't consume salt because that's going to increase to additional fluid retention. The excess retained blood volume is thought to leak out directly from the liver and mesenteric vessels due to increased hydrostatics and vascular wall permeability, and concurrently decreased osmotic fluid retention in the form of hypoalbuminemia. Remember, the liver makes albumin. So if the liver's not making the albumin, then the albumin's not in the blood in order to keep the fluid into the blood and in the vessels. So then it's just leaking out into the abdomen. One of the things that we can do during paracentesis, I mean, we don't technically do it. The nurses will do it and it'll be ordered by a doctor. But a patient who's receiving a paracentesis procedure can receive albumin via IV during or before or after a paracentesis procedure in order to try to help stabilize that equilibrium of keeping the fluid in their vessels. So in order to give that patient some relief, or maybe the providers don't yet know what's causing the ascites, so we can do either a therapeutic or a diagnostic paracentesis. And well, diagnostic paracentesis also could answer additional questions about the disease progression versus just what's causing the ascites. Basically, we run the fluid to lab, and then lab runs the fluid for cytology. So a paracentesis looks like this. We image and show the radiologist where the fluid is. We'll also show the radiologist where the main abdominal wall vessels are so that those can be avoided. Typically the radiologist, sometimes a sonographer, will then clean off the skin, and then that area, the skin is draped with a sterile drape or towels, and then the radiologist inserts this catheter with a needle, and they pull that needle out, and then the catheter is like a coffee stir stick, kind of a little thing. And then they'll attach the hose, the drain, to that catheter that's in that patient's abdomen, and then we'll attach the other end to the collection container that you can see in this picture. And then it's that collection container is either attached to a vacuum system in a wall, or it's already like pre-vacuum sealed. So once we insert that drain into the collection container, it will just automatically suction and pull that fluid out. This procedure takes quite a while, especially depending on how much fluid there is. But if there's a significant amount of fluid, you can be sitting in there for an hour with a patient. So oftentimes these patients with cirrhosis who keep building up the ascites over and over and over again, they keep coming in for a para, and they'll often be like a weekly para patient, and you're sitting with them for an hour talking to them. So you tend to get to know these patients really well. Touched on this already earlier, but can you tell the difference between hepatic steatosis, so that fatty infiltration, and early stage cirrhosis on duplex ultrasound? No, they look the same. They're both big and bright livers. Elastography or biopsy is needed to determine if that patient's liver has moved into cirrhosis. So this bottom picture is showing advanced liver cirrhosis with attenuation. And that top picture where that asterisk is, that's on the caudate lobe. And that appears relatively large, doesn't it? So you can see that ligamentum venosum delineating that caudate lobe. And sometimes it just looks large because it's just comparative to that atrophic right lobe. But also, that caudate lobe has emissary veins. And you'll learn more about this in Vascular 2, learning about hepatic Dopplers. But the caudate lobe has its own little set of veins that will drain directly into the IVC. So if those veins are still patent and functioning, and the liver is cirrhotic, so that liver is cirrhotic and fibrotic, and it's having a difficult time processing blood, right? Because scar tissue, that fibrosis, is non-functioning tissue. So that angiogenesis that we mentioned earlier is happening because it's trying to then reroute the blood through the fibrotic areas. And it's not going to have an easy time to do that. And you're going to, like I said, as far as the effects of that goes, with a portal hypertension, paraumbilical veins, cavernous transformation, main portal vein, caput medusa, you guys are going to learn so much about the effects of cirrhosis and the vascular changes that you'll see. All the varicosities, esophageal varices can be lethal. You'll learn all of that stuff in Vascular 2. But these little emissary veins are patent and trying to get the blood out of this cirrhotic liver, okay? So those guys are working, and then they're working super hard, and so then that caudate lobe experiences hyperplasia and looks big, just like that. Here are a few more images of cirrhosis. These are of late stage cirrhosis with a shrunken liver and ascites. So oftentimes, throughout all of ultrasound stuff, something that is acute is going to be big and dark. I like to think of, the saying of a tall, dark, handsome guy. So tall, dark, and handsome, big and dark. And then chronic things remind me of cosmos, stars. They're small and bright. So thinking about the liver, acute hepatitis, right? Hepatosplenomegaly, hypoechoic, starry night sign. Chronic hepatitis, the liver is not enlarged, and then it's bright. With cirrhosis, acute cirrhosis is going to be big, so that part holds true, but it's going to also be bright, so that part doesn't hold to my mnemonic. The late stage cirrhosis now is going to be small, so we're chronic, now we're small, that part holds true. When scanning a liver, what do we look for when we are interrogating the main portal vein, and why? So as you're doing your protocols in lab and you're scanning that liver and you're looking at that main portal vein and you're putting color on it and you're dropping a Doppler in it and you're doing that from an anterior window and you're doing it from a intercostal window, why are you doing that? Well, and we're also measuring the AP in both windows. We're checking to make sure that the main portal vein isn't dilated. We want it to be under 13 millimeters. 13, unlucky number, right? If it's over 13, that's unlucky, that's bad. Bad things are happening. We are also checking to make sure the blood is hepatopedal, pedal, toward, walking toward the liver, not hepatofugal, fugal away. And we want to make sure that that main portal vein is still patent without thrombosis. These are all possible consequences of cirrhosis, which have further complications of their own. These are some Doppler characteristics of cirrhosis. Again, you'll learn all about this in vascular 2. This first picture is showing some increased blood flow of the hepatic artery. This is in response to intrahepatic hypoxia. It's not getting the blood flow, so the hepatic artery is working even harder. The next one looks like main portal vein is starting to be to and fro flow. It's above baseline and below baseline. It looks like it's blue, and I don't see the color scale, but that looks like it's showing where it's in that reverse flow. So that's not good. And then we see down below a paraumbilical vessel coming through that left lobe of the liver. And then that last one with all that color all over looks like cavernous transformation of the main portal vein. So you'll learn all about that. But basically, cirrhosis is not good, and it's not good for all the vasculature of the liver. And then there's quite sequelae, consequences like domino effect that's going to affect blood flow surrounding that liver as well, toward the spleen, up towards the esophagus, all over. When scanning a liver, why do we evaluate the ligamentum teres? Why are we looking at all these ligaments? Well, they're helpful landmarks to know while we scan, but also we're checking for a recanalized paraumbilical vein. They can be tiny, so we always put power Doppler on that lig teres, and I always recommend to do it in long and also in trans and a cirrhotic liver, and scan through that lig teres area and see if you can find this little vessel that extends toward that umbilical wall. It's going to come up towards you. So one way that radiologists can help determine if a liver has become cirrhotic is they can use this hepatic caudate lobe to right lobe ratio. So they do these measurements here to get the measurement for the caudate lobe and the measurement for the right lobe. If that ratio is greater than 0.65, then that liver is likely to be cirrhotic. So again, that caudate lobe, at least in ratio, is going to be getting bigger than that right lobe of the liver in cirrhosis. An ultrasound abdomen limited does not include a spleen. It's just the right upper quadrant, not the left. You notice sonographic signs of cirrhosis. You know you will not get in trouble for adding the spleen to your scan. Why do you check the spleen? You check the spleen to get measurements because splenomegaly is a common finding of cirrhosis and it has its own additional complications. A lot of patients in our area have cirrhosis. We perform surveillance ultrasound abdomen limited exams on them every 6 months. What is the primary concern? Cirrhosis clearly is bad enough in and of itself. It's got all these different vascular complications. They can develop ascites, but the primary concern is hepatocellular carcinoma. Next diffuse disease, finally, is glycogen storage disease. We are finally moving off of cirrhosis. The next diffuse disease is glycogen storage disease. So glycogen storage disease is an inherited disease characterized by the abnormal storage and accumulation of glycogen in the tissues, especially the liver and kidneys. So there's 6 different categories. The most common is type 1, which is von Gierke disease. It's a form of glycogen storage disease in which abnormally large amounts of glycogen are deposited in the liver and kidneys. You check the age of your next ultrasound abdomen limited scan, which is for von Gierke's disease. What age range are they? Infancy to young adult. Why? Unfortunately, many patients don't live beyond young adulthood who have von Gierke disease. What specifically are you going to look for in your patient with von Gierke disease? You're going to look for adenomas and focal nodular hyperplasia. We'll talk about those more later. Glycogen storage disease. Sono signs: hepatomegaly, fatty infiltration with increased echogenicity and attenuation. Okay, so sounds kind of like fatty infiltration, right? We already know that. If it's storing fat, it's going to look like it's storing fat. With glycogen storage disease, we can also see those hepatic adenomas, and we can see associated nephromegaly. Well, that's unique, but fat is also being stored in that kidney, so that kidney is probably also going to get bigger. Glycogen storage disease and fatty infiltration are hard to tell apart. So what's the one liver pathology that we're learning about that can cause nephromegaly? Glycogen storage disease. Last, diffuse disease, hemochromatosis. Our next diffuse disease is hemochromatosis. So osis means condition of. Oftentimes that condition is having too much of something. So for example, endometriosis is having too many endometrial cells in too many places. Hemochromatosis means heme, blood, chrome, color. So condition of having blood-colored liver. So I included a picture of that blood-colored liver, and it's blood-colored because remember, blood has iron. So hemochromatosis is having too much iron in that liver. So hemochromatosis is a rare disease of iron metabolism characterized by excess iron deposits throughout the body. So this may lead to cirrhosis and portal hypertension. Sonographic findings include hepatomegaly, cirrhotic changes, increased echogenicity may be seen uniformly throughout the hepatic parenchyma. So sounds a lot like fatty infiltration. Again, interestingly, under ultrasound, the iron deposits in the liver don't alter that liver echogenicity, even though it's altering the color of the liver. So if sonographic liver abnormalities are present, they're usually secondary to that cirrhosis development. Just to reiterate, out of our diffuse diseases, which ones in our notes can lead to cirrhosis? All of them. Our ultrasound machines can perform liver elastography as long as that package has been bought. The main idea behind elastography is that the elasticity of the analyzed tissue can offer information on the health of that organ. So a stiffer liver tissue usually indicates the presence of the consequence of any chronic liver disease, the fibrosis. Okay, so elastography is for the liver, used to determine how fibrotic it's become. So in addition to our ultrasound machines, there's a device called FibroScan that GI providers can also use just in office to measure how fibrotic someone's liver is just by holding this device toward their liver, like through their ribs. It sends in signals, and then as they come back, it analyzes them. And there's a couple different ways that that can be done. In fact, there's different types of elastography that can be done under ultrasound. And you've probably learned a little bit about elastography or the concept of it during physics. So now we're moving right along, getting into infectious/inflammatory diseases of the liver. In addition to hepatitis, the 6 infectious diseases that we'll be going over are pyogenic abscess, fungal abscess, echinococcus cyst, amoebic abscess, schistosomiasis, and chronic granulomatous disease. This chart outlines all those different infectious diseases, including hepatitis B. It tells you who the culprit is. It tells you how they get to that liver. It tells you some specific things about that particular infection, and then also tells you about the sonographic signs of that disease. So this is a nice comparative graph that I wrote up for you. You're welcome. First infectious disease is pyogenic bacterial abscess. Our first inflammatory disease of the liver is a pyogenic abscess, pyo meaning pus. Hepatic abscesses occur most often as complications of biliary tract disease, surgery, or trauma. These are bacterial infections, often caused by E. coli. You're probably familiar with E. coli. It tends to be a culprit in food poisoning or urinary tract infections. So since it's a bacteria in the biliary tract disease, a little mnemonic for you could be bacteria. The following 3 basic types of abscess formation occur in the liver: intrahepatic, subhepatic, and subphrenic. So subphrenic means below the diaphragm, which would put you just above the liver. So I can't really think of another location around the or in the liver, so that would make sense. Intrahepatic, subhepatic, and subphrenic. Clinically, the patient has fever, elevated white cell count, and right upper quadrant pain, and that pain can shoot up into pleuritic pain, especially if it's subphrenic, so that pleural lining of the lungs can hurt with pyogenic abscess. That makes sense. Location, painful, yuck. On sonographic examination, make sure that you're looking for solitary or multiple lesions in the liver, abnormal fluid collections in Morrison's pouch or subphrenic space, and also check out microbubbles. Make sure that you're looking to see if you see any microbubbles. If you do see microbubbles, that's not a good sign. That's typically indicative that that bacteria is doing too much, making its own air in there. Not good. So some of these abscesses in these pictures kind of just look like cysts. Some of them look a little bit more complicated than others. One of them looks really gross with a bunch of microbubbles. You can see that in the bottom left picture. That top right picture just kind of almost looks like a hypoechoic mass with irregular borders. It's kind of hard to tell that that's specifically an abscess. If we could see a little bit more of the posterior border there, we'd likely see some posterior acoustic enhancement. So remember from your physics, as the sound waves travel through fluid, the sound waves don't get absorbed as much as they do in the surrounding tissue, so the echoes beyond it are going to return brighter. So there's probably some indication there that that's an abscess, and or otherwise we're also going to have the clinical findings, the symptomology that can help us identify that that's likely an abscess there. So what's a differential diagnosis for a potential pyogenic abscess? Well, again, if you remember those other ultrasound images, it looks a lot like some cysts or fluid collections such as blood, so hemorrhage or necrosis. We can see necrosis with various disease states and cancers. Next infectious disease is Candidiasis abscess. Our next inflammatory disease is fungal infection, often caused by candidiasis. Also tends to be the culprit in yeast infections for women. This liver infection tends to occur in immunocompromised people. Again, that organism is a candida. Causes small abscesses in the liver, making for several different appearances. Sometimes a needle aspiration biopsy needs to be performed in order to help differentiate the candidiasis from lymphoma. So lymphoma and fungal infections might look similar. We will talk more about lymphomas later. Here are some ultrasound images of different appearances of fungal infection. Typically hypoechoic overall, and typically multiple. And we'll talk about some specific sonographic signs of them. So here's going to be one inflammatory disease, in addition to acute hepatitis, I should say, in which we'll see hepatomegaly. But with the fungus amongus, they want to go party. So they're going to get in a car with wheels within wheels in order to go throw darts at a bullseye. Okay, there's your little mnemonic, fungus amongus, wheel within a wheel, and bullseyes. So what we can see is hepatomegaly, uniform hypoechoic lesions, and then early stage, so the wheels come first, wheel within a wheel. There'll be an outer wheel, that's a hypoechoic rim, an inner wheel with an echogenic zone, and then an inner nidus. So nidus is just like a little central portion, hypoechoic nidus there. And then bullseye will be late stage, and you're also going to hear bullseye as we discuss another pathology later on. So just kind of tuck that in the back of your mind that fungus amongus, the candidiasis, is not the only friend that has that bullseye sign, okay? So bullseye has a central echogenic part, a hypoechoic rim. And then this image here from pediatric radiology is also showing this wagon wheel sign. You can take a look at that there. It looks like it has 5 different spokes. Almost looks like a guy, kind of like a stick figure in there. So wagon wheel is a potential additional sign that you might need to know about for a board exam, but was not in our notes for your upcoming liver exam. Next infectious disease is echinococcus. If you don't know yet, there are organizations that do mission trips to countries that don't have access to various healthcare, such as ultrasound. So many sonographers will go on these mission trips and help out the locals there. So we might not see a gonococcal cyst here very much in the United States, but if you go on a mission trip, if that's something that you'd like to do, you might see it wherever you go. One such place that you might see it would be in areas of India. So a gonococcal cyst or hydatid disease is caused by an infestation by the parasite, which is a tapeworm, called Echinococcus granulosus. It's prevalent in sheep and cattle raising countries, especially where dogs are used for herding and grazing sites. The eggs are excreted in dog feces. Humans, cattle, and sheep are used as intermediate hosts. Eggs are swallowed and hatched in the intestines and penetrate the intestine wall and mesenteric venules. Then the larvae enter the liver via the portal vein. One of the other infectious diseases will come in through the portal vein. The cysts have 2 layers, inner and outer layers. The outer is actually the reaction or inflammatory layer. Hydatid disease, the echinococcal cyst, has a step-by-step progression of its lifespan. Number 1, simple fertile cyst. 2, daughter cyst. 3, cyst with detached endocyst, the water lily sign. 4, solid appearing cysts. 5, calcified cysts, inactive. I have a strange little mnemonic for you. Hopefully it helps you remember these because you'll need to know these in order. So 1, there's a simple fertile lady. 2, she has a daughter. 3, she becomes detached from reality and decides to go get a water lily sign. 4, she gets her life back together and now she's solid and sound. 5, but then she dies and her calcified bony skeleton is now inactive. Told you it was weird, it's morbid, but hopefully it'll help you remember. Okay, to be fair, if I had this many daughters, all these daughter sis, I would probably lose my grasp on reality as well. Simple fertile cyst, daughter cyst, detached endocyst, the water lily sign, solid appearing, and then calcified. You can tell that that last one's calcified because you can see that shadowing from that echogenic circle. That one, though, has the shadowing, which differs from just that solid appearing one. Moving on to the next infectious disease, amoebic abscess. Our next inflammatory disease is amoebic abscess. So an amoeba is a type of protozoa. So it's a parasite. Amoeba live in warm, fresh water, such as lakes and rivers. So you know how they always tell you, like, don't drink pond water or standing water, that you'll get sick? You can get an amoeba and you can get an amoebic abscess in your liver. Okay, so this is contracted by ingesting contaminated food or water. So don't wash your food in that pond either, right? Then this parasite will enter the intestinal tract and live in your colon. Gross. Causes a collection of pus. Ooh, also gross. Formed by disintegrated tissue in a cavity. So pyogenic is bacterial, and that's pus. Amoebic abscess, and also form pus. The parasite enters the liver via the portal vein after invading colon mucosa. So portal vein, protozoa into the colon, okay? Or protozoa into the colon and the portal vein. However you want to say that, just a nice little mnemonic for you to help you remember. An amoebic abscess formation is usually in the peripheral areas of the liver. So if you like, you can even add the word peripheral into this little mnemonic. So protozoa into the colon, portal vein, peripheral. That's a bunch of P's, but not pyogenic. Talking about protozoan, amoebic. Here's an ultrasound image of an amoebic abscess, and look how it's sitting peripherally down near that diaphragm. Schistosomiasis is our next infectious disease. Next inflammatory disease is schistosomiasis. I like to think of it as a stabby schizo. Here you are just minding your own business, tending to your rice paddy in the water, and here comes this parasitic worm that stabs you, punctures your skin, and then goes to your liver. And how does it get there? That tapeworm larva punctures skin and migrates to the liver via lymphatics and venous system. Those larvae mature into worms and cause granulomatous reaction and fibrosis. We've heard about fibrosis along the portal vein branches. Terminal portal vein branches become occluded, leading to portal vein hypertension, splenomegaly, varices, and ascites. This should sound very familiar. Liver small or normal. Increased echogenicity of intrahepatic portal vein wall radicals. Radicals are like the roots of the branches. Portal vein dilatation, splenomegaly, so think small cirrhosis, so like advanced stage cirrhosis. In this ultrasound image, all that echogenic, very hyperechoic, all those lines represent that periportal fibrosis. So typically fibrosis of fibrous tissue is going to be hyperechoic, more echogenic throughout the entire body. This ultrasound of schistosomiasis has this fish scale appearance. In these ultrasound images, you can see that increased echogenicity of the portal vein wall radicals. You can see that dilated portal vein, and you can see that splenomegaly. So again, remember, schistosomiasis, small cirrhosis, schistosomiasis, small cirrhosis, schistosomiasis, small cirrhosis. Help you remember that. Chronic granulomatous disease is our final infectious inflammatory disease. Next inflammatory disease is chronic granulomatous. So we just talked about granulomatous changes. You can have granulomatous changes just about anywhere in your whole body. Granuloma looks like, under a microscope, that picture that's right there in that upper right hand corner, and they look like all those little purple stained dots look like little small grains, and that's where granuloma comes from. And granulomatous changes happen when there's areas of increased infection, inflammation. So chronic granulomatous is a genetic disorder where phagocytes are unable to kill certain bacteria and fungi. Now, chronic granulomatous disease is more common in males because it's recessive. A little mnemonic is guys have grans. Little boys tend to love their grandmas. Under ultrasound, chronic granulomatous disease might appear like poorly marginated masses, hypoechoic, posterior enhancement. Those all sound like abscesses or even hematomas. Areas after a while can become calcified. Typically that's an inactive area, again, with calcifications. And again, you can find these granulomatous changes all around the body, especially when they look calcified like that. But my goodness, the other forms look a lot like, well, abscesses. Finally, moving on to focal hepatic lesions. First, we'll start with cysts, then we'll talk about benign, and then we'll talk about malignant. Neoplasm means new growth. That plas part you've also seen in hyperplasia. So plasis means formation. A neoplasm can be benign or malignant. A mass. A mass is a three-dimensional lesion that occupies space. A lesion is an area of abnormal or damaged tissue caused by injury, infection, or disease. Both masses and lesions can be either benign or malignant. If your patient hears or sees the words neoplasm, mass, or lesion, they're going to think that you mean malignant, or that the radiologist means malignant. Typically, when I describe something under ultrasound, I'll just say area. If I am giving results to a patient, as I do with breast imaging, because I've shown the radiologist tells me what they think, I get to go back and tell the patient. I'll tell them an area. There's an area that was seen. I will not use the word neoplasm, mass, or lesion, because I don't yet know if that area is a cancer, regardless of how suspicious it may look under imaging. But neoplasm, mass, lesion, all of those can be benign or malignant. So how do we know how suspicious something looks under ultrasound? How suspicious does it look for a cancer? Malignant versus benign. Benign growth occurs locally but does not spread or invade surrounding structures. It may push surrounding structures or adhere to them. A malignant mass does not care and does what it wants. It's uncontrolled and is prone to metastasize to nearby or distant structures via the bloodstream and lymph nodes. Masses can be extrahepatic or intrahepatic. So a liver mass might be within the liver or it might be kind of going out of the liver. So an intrahepatic mass may cause displacement of the hepatic vascular radicals, external bulging of the liver capsule, or a posterior shift of the IVC, right? Picture your left liver long as you're coming all the way medial and you've got that caudate, you've got IVC, right as you're entering in a right lobe, that IVC is right there. And you can see that IVC looks like it's just right in between that anterior and posterior lobes of that right lobe, those sections of that right lobe. So if there's an intrahepatic lesion, saying that like anterior portion of that right lobe, then it might push back onto that IVC. Now, extrahepatic masses may show internal invagination or discontinuity of the liver capsule, formation of a triangular fat wedge, anteromedial shift of the IVC, or anterior displacement of the right kidney. That right kidney is like all the way in the back as it is. When you scan kidneys, oftentimes we'll be scanning from the posterior aspect. So a mass really isn't going to push that kidney any further back, but it might push that kidney forward more anterior. After we perform our ultrasounds, we have to describe our sonographic findings of lesions. So the first thing is we're going to describe the location, describe where it is both in long and in trans. Is it lateral mid-medial? Is it superior mid-inferior? Show the location in your sweeps. And then after you've shown your sweeps and where it is within that liver, then you can zoom in on that lesion and to really show the characteristics of that lesion. You're going to measure it, show the size of it. You're going to describe the echogenicity. Is it hyperechoic to the rest of the liver? Is it hypoechoic? Is it heterogeneous? Is it echogenic? You're going to describe the borders. Are they smooth, irregular? Are they well circumscribed? So are they well marginated or not? Describe the shape of it. Is it round? Is it oval? Is it lobulated? Is it, again, irregular shape? Describe the posterior features. So what's going on behind it? Does it have that posterior acoustic enhancement or does it have shadowing? Describe the vascularity. Is there peripheral vascularity? So around it, is there internal? Is there a spoke sign? Is it low resistive Doppler? And then describe any of the sonographic signs. Do you get twinkling artifact with color? Do you see a water lily sign? Do you see a bullseye sign, etc.? One day you're going to be out in the field, you're going to be scanning, and you're not going to have your notes with you. It's a sad thing, but Radiopedia will be there to save you. Radiopedia is also where your radiologist is going to look if they're uncertain about something. Radiopedia is a great resource for you. They list liver tumors. So this list is showing primary benign tumors and primary malignant tumors. There's quite a few more than what we're learning about. So you don't have to focus on them, just know that this resource exists. Liver tumors is one page in Radiopedia. Liver lesions has another page of its own as well in Radiopedia. When you're scanning something, you're probably going to find like a hyperechoic area, a hypoechoic area, or a cystic area. And then you're going to wonder, what was that? What's the differential diagnosis for a cystic area, a hyperechoic area, or a hypoechoic area? Here's a nice list of cystic lesions of the liver, a differential diagnosis list. Hyperechoic liver lesions. Here's a differential diagnosis list. I'd like to point out that it says that a benign hepatic hemangioma is the most common entity encountered. but in patients with atypical findings or risk for malignancy, other entities must be considered. But if they're not at risk, they're going to say it's likely a hemangioma and leave it alone. Here's a list of pediatric liver lesions. So the only list that we're missing is a hypoechoic differential, but they don't have one. There are 2 focal hepatic lesions that are not otherwise specified, cysts and polycystic liver disease. Focal hepatic lesions, cysts. Simple hepatic cysts. True cysts are congenital, someone's born with it. They're rare and usually solitary. Cystic masses that result from trauma, parasites, inflammation are not true cysts. A simple cyst has the same criteria no matter where they live. So a simple cyst needs to be anechoic, well circumscribed with posterior acoustic enhancement. This bottom picture shows a complex cyst that has internal echoes. This one is complicated with hemorrhage. The next focal liver lesion is adult polycystic disease. The next focal lesion is polycystic liver disease. It looks like a lot of cysts because it's a lot of cysts, hence polycystic. Polycystic liver disease is an inherited condition. It's inherited in an autosomal dominant pattern. Most of the patients have polycystic renal disease. So when you scan the liver, if you see a whole bunch of cysts, you should be scanning the right kidney anyway. Some facilities don't, but you should probably throw in a kidney, at least one. It affects females more than males, occurs in the 5th to 7th decades of life. The 5th decade of life refers to someone in their 40s, by the way. Cysts are small, 2 to 3 centimeters, and multiple. Liver function tests are usually normal, and there's no association with hepatic fibrosis and portal hypertension. So even though polycystic liver disease might look like there's not a whole lot of functional parenchyma left, it's all working just fine. Here's a cystic area in this liver. This is a cancer. This is hepatic cystadenocarcinoma. So if cystic areas can be both benign and malignant, how can you differentiate between different types of cystic masses? Number 1, turn up your B mode gain and look for septations, internal echoes, and solid nodules. Use color. Color is your friend. Evaluate borders. Assess for other masses present that may show other signs. Use your clinical signs and patient history that's available to you. And sometimes they have to do short-term follow-up imaging or they have to aspirate and biopsy. Benign tumors. Benign liver lesion, cavernous hemangioma. Our first benign focal lesion is cavernous hemangioma. Hemangiomas are the most common benign tumor of the liver. They are congenital benign tumors made up of large blood-filled cystic spaces, hence cavernous. Heme means blood, angio means vessel, oma means tumor. Majority are small, asymptomatic, and discovered incidentally. They're frequently in women. They're typically located in the posterior right lobe more often than the left lobe. Pretty much everything's more often found in the right lobe because the right lobe's twice as big. They're usually stable in size, but may enlarge and show evidence of degeneration, fibrosis, and calcification. They can infarct. A cavernous hemangioma is typically going to be hyperechoic. It's going to be round. It's going to be well encapsulated with a smooth border. And you may or may not see any posterior features. If you see any posterior features, it'll be posterior acoustic enhancement. Next benign tumor is liver cell adenoma. We'll also be talking about focal nodular hyperplasia intermittently about the same time. and then following. Our next focal lesion is the liver cell adenoma. Adeno means gland. There are many glandular structures throughout our bodies, and a lot of them can develop adenomas. A lot of them can also develop their cancer sister called the adenocarcinoma, and they'll typically look cystic, so it'll be a cystic adenocarcinoma. Just like our liver cell adenoma, it can also turn cancerous, and that's why liver surgical resection is recommended. Now, this area is called a gland because hepatocytes excrete stuff, and so therefore they're considered glands. So the difference between focal nodular hyperplasia and liver cell adenoma is the absence of the bile ducts and those Kupffer cells in the liver cell adenoma. It's just the hepatocytes, it's just the glandular. Focal nodular hyperplasia is that overgrowth in a nodular focal form of all of those things, okay? It's less common than focal nodular hyperplasia, which is good because this can get sassy. It may have spontaneous bleeding as well. Like focal nodular hyperplasia, a liver cell adenoma can also vary in its echogenicity. Here's examples of a hyperechoic, a hypoechoic, and a heterogeneous area. That hyperechoic kind of almost looks like a hemangioma, but it kind of looks like a raining cloud, doesn't it? So those borders aren't quite as smooth as a hemangioma, probably. It's got that shadowing, which typically we're not going to see with a hemangioma. And it's more oval than it is round. So remember, shape, the size, the borders, those posterior features are all going to be very relevant in your descriptions. Time to get more in depth with our benign tumor, focal nodular hyperplasia. Focal nodular hyperplasia is the second most common benign tumor after hemangioma. It's usually also found incidentally. It's composed of abnormally arranged hepatocytes, Kupffer cells, remember those phagocytes, bile duct elements, and fibrous connective tissue. So it's basically an overgrowth hyperplasia in a nodule form, nodular, then it's focal in one spot. Focal nodular hyperplasia is going to have all of the parts. A focal nodular hyperplasia is going to have well-defined borders. It's going to be variable in echogenicity, hyperechoic to isoechoic to hypoechoic. It's going to have a central scar, which you might be able to see if you look really closely at that B mode, especially the upper picture here, that one that's measured at 7.2 centimeters. But one of the distinguishing features about focal nodular hyperplasia is the color. Color Doppler may show peripheral and central blood vessels that go into that focal nodular hyperplasia lesion, and it'll look like the spoke sign. So both adenomas and focal nodular hyperplasia have increased incidence in populations that take birth control and glycogen storage disease. Remember that? Now, adenomas and focal nodular hyperplasia can look alike, but adenomas require surgical excision because they can become cancerous. Can you see in that B mode how that focal nodular hyperplasia seems to have that central scarring? Kind of see that better? But they do look pretty similar. Again, put color on them. That focal nodular hyperplasia is going to have arteries entering the area of the central scar and then spoke out. Hepatocellular adenoma is going to have vessels throughout multiple sites in the periphery, but it's not coming in through that central scar. Moving into the pediatric benign liver tumors, we have infantile hemangioendothelioma. Now, benign pediatric tumors. Infantile hepatic vascular tumor, otherwise known as infantile hemangioendothelioma. And actually, per Radiopedia, it's just been renamed to a hemangioma. It is a benign condition due to the overgrowth of the endothelium of minute capillary vessels that occurs in infants. It is the most common benign vascular tumor in infancy. It also happens to be symptomatic. It's benign, but it's sassy. It's more common in females, 2 to 1. It grows rapidly after presentation, then regresses slowly by 12 to 18 months of age. An infantile hemangioendothelioma is a rapidly growing abdominal mass. It shows elevated AFP. Only a few of our pathologies do. We will summarize those later. It has a cutaneous hemangioma. There's hepatomegaly associated. Congestive heart failure is high and second to arteriovenous shunting throughout the liver. There's thrombocytopenia, angiopathic anemia, GI bleeding, and intra-abdominal rupture with hemorrhage. There's a lot going on with blood. Infantile hemangioendothelioma, again, is a vascular tumor. So on ultrasound, you're going to see large draining veins. You might see a dilated prox aorta. Color can show high flow in dilated vascular spaces and may show that arteriovenous shunting. Our final benign liver lesion is another pediatric tumor, a mesenchymal hamartoma. Our last benign tumor is also a pediatric tumor. It's mesenchymal hamartoma. Hamartoma comes from hamartia, which means erroneous. So a hamartoma, wherever it is usually just an erroneous configuration of the typical cells, the parenchyma, that's usually there within that organ. Now this one is talking about a mesenchymal hamartoma. So mesenchyme is a loosely organized, mainly mesodermal, embryonic tissue which develops into connective and skeletal tissues, including blood and lymph. So if you remember learning about embryology, you've got those, the mesoderm, the endoderm, and the ectoderm. This is mesoderm, okay? This is rare, it's developmental, not encapsulated, cystic tumor. While mesenchymal, connective tissue, blood and lymph, that makes sense. It has a variable appearance in imaging studies ranging from multiple small cysts, which sometimes can look like a solid mass, to a multilocular cystic mass with solid septa. It may have a lace-like configuration. That bottom right picture kind of looks almost like a doily. It looks very lace-like. Moving into the malignant hepatic tumors. In keeping with the pediatric theme, our first malignant tumor is a hepatoblastoma. Hepatoblastoma is a rare malignant germ cell tumor seen in infancy and childhood, most frequently in children under the age of 4, with the majority under 1. It's the third most common abdomen malignancy in children. It's considered the infantile form of hepatocellular carcinoma and may be familial. Unlike hepatocellular carcinoma, it is not associated with hepatitis. Hepatoblastoma is also associated with precocious puberty, meaning puberty before the typical normal puberty age. As you're scanning, look for high velocity, low resistance blood flow, which is probably going to be pretty common for the majority of malignancies. It's growing rapidly. It wants all that blood flow. Check that main portal vein for thrombosis. Again, we're talking about a cancer, and cancers will invade vessels. They don't care. Typically, a hepatoblastoma is solitary and big. It's heterogeneous with solid cystic anceptations. It'll often have poor borders, as many cancers do. And occasionally, you'll see calcifications. And calcifications within cancers are often due to necrosis. It's due to that cancer outgrowing that blood supply so fast that then it dies in little bits. It doesn't die and go away, unfortunately. What is the third most common abdomen malignancy in children? Hepatoblastoma. Second is nephroblastoma or Wilms tumor, so one of the kidneys. And the most common abdomen malignancy in children is neuroblastoma. Children should be having a blast, not a blastoma. You'll learn about blastocysts in OBGYN. Blastos means sprout, and it's a suffix meaning an embryonic state of development or the creator of a type of cell. What is the second most common liver malignancy in children? Hepatocellular carcinoma. You're doing a second trimester anatomy scan and see this in the liver of the fetus. What is this? It's a hepatoblastoma. The next malignant tumor is hepatocellular carcinoma. Here are two gross pathology examples of hepatocellular carcinoma. A, the cirrhotic liver contains a solitary malignant nodule, and B, the huge tumor is poorly demarcated from the remaining liver. Hepatocellular carcinoma, or a hepatoma, is the most common primary malignant tumor of the liver. The most common malignancy in the liver is METs, but the most common primary malignant tumor of the liver is hepatocellular carcinoma. It occurs more frequently in men. It's the second most common liver tumor in children, usually over 3 years old. It has a tendency to invade the venous system, and cirrhosis is the most common predisposing factor, 80% of cases. Your patient for an ultrasound abdomen limited is a sweet, chatty, energetic lady who had slightly elevated LFTs. You put down the probe, and to your surprise, you see a large mass. Why is your patient asymptomatic? Symptoms of hepatocellular carcinoma are often delayed until tumor reaches advanced stages. When there are symptoms and clinical indications of hepatocellular carcinoma, what are they? 1, palpable mass or rapid liver enlargement. 2, unexplained mild fever. 3, a mix of signs and symptoms associated with cirrhosis, which makes sense. 4, LFTs are often normal, but they may have elevated AST and ALT. And 6, 70% have increased AFP. Hepatocellular carcinoma may occur in one of 3 ways. It could be one solitary massive tumor, 2, it could be multiple nodules throughout the liver, or 3, there can be diffuse infiltration. Invasion of vessels and biliary tree are common. That diffuse infiltration can be tricky and can be very challenging to see. Invasion of the hepatic vessels can cause Budd-Chiari syndrome, which is hepatic vein or IVC obstruction. And you'll learn more about Budd-Chiari syndrome and the sequelae of that in Vascular 2. Hepatocellular carcinoma under imaging. Smaller tends to be hypoechoic, larger tends to be hyperechoic, but isoechoic and hetero are also possible. Again, cancer does what cancer wants. But smaller lesions reminds me of focal fatty sparing. So when you're scanning, you need to make sure that you're really differentiating, is this a small hepatocellular carcinoma or is this just focal fatty sparing? How can you tell? A patient can get ascites with cirrhosis and hepatocellular carcinoma. The next malignant liver lesion is the lymphomas. Lymphomas are our next malignancy. You'll learn about lymphoma over and over and over again every time we talk about an organ. Lymphomas are malignant neoplasms involving lymphocyte proliferation in the lymph nodes. There are two kinds, Hodgkin's and non-Hodgkin's. I give you more information about them because you'll end up needing to know them. Hepatic lymphoma presents in presence of advanced disease elsewhere and is of the non-Hodgkin variety. Primary hepatic lymphoma usually occurs in immunosuppressed people. Primary hepatic lymphoma means that the lymphoma originated in lymph nodes in the liver, which are located along the hepatic artery, at the bifurcation of the GDA, and at the neck of the gallbladder. Lymphoma, FYI. Hodgkin's lymphoma has Reed-Sternberg lymphocytes, which a physician can identify using a microscope. Non-Hodgkin's lymphoma doesn't. So the physician would be a pathologist looking at histology. Okay, so they do a biopsy, then they can look at the cells, and that's how they determine if it's Hodgkin's or non-Hodgkin's. Non-Hodgkin's is more common. Most non-Hodgkin's patients are over the age of 55 when first diagnosed, whereas the median age for diagnosis of Hodgkin's is 39. Non-Hodgkin's may arise in lymph nodes anywhere in the body, whereas Hodgkin's lymphoma typically begins in the upper body, such as the neck, chest, or armpits. So lymphoma, Hodgkin's is usually diffuse. Non-Hodgkin's lymphoma are typically targeted hypoechoic lesions. So think hockey pucks. Also, there's bullseye, which shows necrosis. Doesn't that sound familiar? Like a fungal infection. Again, primary hepatic lymphoma is rare, non-Hodgkin's lymphoma, and usually seen in immunosuppressed people. Here are some lymphoma examples. You can see a bullseye in there, and otherwise look kind of like hockey pucks all over. All right, friends, we've made it. Our final liver pathology is the malignant metastasis. Metastasis is the most common form of any malignancy of the liver. Mets occur from tumor cells to the liver by portal vein, lymphatics, hepatic artery, and less often by direct extension. I'm not really sure that there's any other ways to get to the liver. They cause hepatomegaly. Ultrasound appearance is not specific for determining origin, but generalities apply, and you'll need to know them. Liver is the most common site for Mets, even more so than hepatocellular carcinoma. In fact, it's so common for Mets that oftentimes first an area will be identified in the liver as suspicious, and then when it's biopsied, that's when the primary cancer is actually determined. Or a patient will have symptoms of a cancer and they won't be able to find it, and they'll look in the liver and biopsy the liver and find it. Common primary sites include the colon, breast, and lungs. In fact, breast cancer likes to spread to the lymph nodes and the bones and the liver and the brain. You don't have to know that about where breast spreads unless you end up taking breast boards, but just FYI, the liver is very, very common for breast cancer to go to. So common primary sites include colon, breast, and lungs. Mets to the liver often comes from colon, lung, and breast. Just like hepatocellular carcinoma can appear in 3 different ways, Mets may also appear in 3 following patterns: a well-defined hypoechoic mass, a well-defined echogenic mass, or diffuse distortion of the normal liver parenchymal pattern without focal mass. Again, diffuse distortion is often very challenging to see under ultrasound. Metastatic disease, it's common to have hepatomegaly, increased ALP, abnormal LFTs, increased direct bilirubin, jaundice, and pain. To recap, elevated AFP is seen in infantile hemangioendothelioma, hepatoblastoma, and hepatocellular carcinoma. So 2 cancers and a sassy thing. Elevated ALP is seen in METs. What's the difference? Elevated AFP. So alpha-fetoprotein is a protein the liver makes when its cells are growing and dividing to make new cells. Therefore, this protein is usually only seen being made by a fetus's liver. You'll hear more about this protein in OBGYN 2. A liver that is making new cells again is likely growing its own cancerous liver cells. The exception is infantile hemangioendothelioma, but while this is benign, it is a sassy condition in an infant. This is also why we usually do not see an elevation with metastatic disease to the liver. Echogenic METs are typically vascular METs and come from hepatocellular carcinoma, GI tract, or renal cell carcinoma. Hypoechoic METs are typically hypovascular and are lymphoma. Bullseye or target pattern METs come from lung. There's bullseye again. So we've seen bullseye in lymphoma, in fungus, and now again in METs. Calcified METs comes from the colon. Remember, colon is one of the 3 primary places that METs comes from. Cystic METs can also be colon. It can also be ovary and pancreas. Ovaries and pancreas often will have cystic type cancers. So that makes sense. The diffuse disorganization of liver parenchyma is typically indicative of an infiltrative form, and that's going to come from breast and lung, the other 2 common, and melanoma. Breast, lung, melanoma, infiltrative form. How do metastatic cystic tumors look different from simple liver cysts? 1, they have thick walls. 2, they'll have nodules. You can see a big chunky nodule hanging out in that more posterior one and a little nodule in that more anterior one. There's septations and fluid levels. So you can see the echoes like moving. You can tell that they're fluid, but there'll be different densities and one fluid will sit on top of the other. It's kind of like oil and water. Ultrasound may be used to monitor progression in size and extent of METs or the decrease in size and extent. It can also look for pattern change and monitor response to chemo. Here's metastatic disease appearing as multiple well-defined hypoechoic lesions throughout the liver. These 2 metastatic disease images really show the exact opposite appearance that METs can take. More METs pictures. With all of that information that we've just learned, what patterns do we see? A 1-year-old child has a rapidly enlarging liver. What's the differential diagnosis? 1, infantile hemangioendothelioma. 2, mesenchymal hamartoma. 3, hepatoblastoma. Or 4, hepatocellular carcinoma. What pathology is associated with hepatomegaly? Fatty infiltration, hepatitis, cirrhosis early, glycogen storage disease, hemochromatosis, fungal infection, infantile hemangioendothelioma, hepatoblastoma, hepatocellular carcinoma, and METs. Splenomegaly can be caused by hepatitis, cirrhosis, and schistosomiasis. You find a hyperechoic area in a liver. What's the differential diagnosis? What could that be? Focal fatty infiltration, hemangioma, adenoma, focal nodular hyperplasia, hepatocellular carcinoma, METs, or trauma. You find a hypoechoic area in the liver. What could it be? Focal fatty sparing, candidiasis, chronic granulomatous disease, adenoma, focal nodular hyperplasia, hepatocellular carcinoma, lymphoma, or METs. You find a cystic area in the liver. What could it be? Cysts, hemorrhagic cysts, necrotic tumors, hepatic cystadenocarcinoma, echonococal cyst, abscess, or hematoma. In addition to the aforementioned pathology that we can find within the liver, there are other things that we can find in the liver. There are various hyperechoic foci and trauma that we can see. You see hyperechoic foci in the liver or achogenic. What could it be? It could be air in the bile duct. It could be calcifications. It could also be foreign objects. You'll see them after cholecystectomies. You'll see surgical clips. Calcifications can be from granulomatous change or a healed abscess or hematoma. Also, remember, hydatid cysts turn calcified at the end. Air and bile ducts can be from post-op biliary surgery or infectious agents cause comet tail artifact. So we talked about microbubbles in the biliary tree with pyogenic abscesses. And then foreign objects, like I said, surgical clips or foreign metal pieces such as shrapnel. Yikes. Again, what are 3 benign causes of hyperechoic foci in the liver? Calcs, air, and foreign objects. Hepatic trauma. The liver is the 3rd most common organ injured in the abdomen after the spleen and kidney. Liver hematoma can result from injury or rupture of neoplasm. In children, blunt trauma accounts for 90% of all abdomen injuries. May present with decreased hematocrit. There are 3 categories of liver trauma: rupture of the liver and its capsule, separation of the capsule and the subcapsular hematoma, central rupture of the liver. A ruptured subcapsular hematoma will be difficult to visualize. The sonographic appearance of a hematoma is going to change over time. The sonographic appearance of blood changes over time. Okay? An acute bleed is going to be echogenic at first due to fibrin and erythrocytes in it. Then it's going to kind of settle a little bit and become hyperechoic in the first 24 hours. Thereafter, it'll be hypoechoic and sonolucent. Synonym for sonolucent is anechoic, which we use more often. Thereafter, because of resolution of blood. Then septations and internal echoes develop about 1 to 4 weeks after trauma. Looks kind of like coagulated, stringy blood. And generally, hypoechoic with poorly defined margins will be the sonographic appearance of a hematoma. So echogenic down to hyperechoic, down to hypoechoic/anechoic, and then stuff forms in it. Here is a chart of the sonographic appearance of a hematoma across time, when it looks that way, why it looks that way, and how it looks. This infographic from radiopedia.org shows the different grades, so different severity of hepatic trauma. Here are some more hepatic trauma images. The liver functions. The liver does so much. The 5 main liver functions are metabolic, detoxification, secretory, formative, miscellaneous. Metabolic functions can be broken down into the carbohydrates, the proteins, the fats, and the others. So for carbohydrates, there's glycogenesis, glycogenolysis, and gluconeogenesis. For proteins, the liver makes structural proteins, enzymes, albumin. Albumin draws water into the vascular system, which helps maintain oncotic pressure, aka colloid osmotic pressure, which prevents ascites, and blood coagulation. So it makes heparin to make sure that the blood doesn't overcoagulate, and then other proteins to make sure that it coagulates enough. Metabolism of fat converts fat into glucose, cholesterol, and/or phospholipids. Phospholipids are structural components of cell membranes, and cholesterol is the main component of bile used to emulsify fats. That'll be important next chapter. Other metabolic. There's storage of vitamins and minerals, formation of vitamin A, metabolism of steroid hormones, and degradation and detoxification of drugs. Detox functions. Removes harmful substances absorbed by intestines from the blood, converts harmful substances into useful or excretable substances. Those Kupffer cells are specialized phagocytes. We've talked about that. Bilirubin is the byproduct of hemoglobin breakdown and excreted via the biliary system in the feces, gives bile its pigmentation. Formative, there's albumin, fibrinogen, prothrombin, globulins, heparin, lymph fluid. That prothrombin is going to help prevent not coagulating well enough. And that heparin is going to prevent coagulating too much. So serum proteins are those proteins that are in the blood as produced by the liver. The decrease with hepatocellular disease will be seen within the blood. So that decrease can lead to ascites because of loss of albumin. Decrease can lead to DVTs due to loss of heparin. And decrease can lead to excessive bleeding and bruising from loss of prothrombin. Finally, the liver is a reservoir for blood and a source of heat. Spleen is also a reservoir for blood, remember? Here's a nice chart for you of different liver function tests. AST is very sensitive, but not specific. ALT is going to be more specific than AST, and it also increases with biliary obstruction. ALP, a marked increase of ALP in a non-pregnant adult signals bone or liver abnormalities. And LDH is going to be more related to chronic hepatocellular disease. There are two types of bilirubin, direct and indirect. Direct is soluble, conjugated. This one's more for obstruction. Think directly in the way. Indirect is albumin bound, unconjugated. This is going to be related more to hepatocellular disease and disorders causing increased red blood cell destruction. Think indirect albumin bleed-in. Total bilirubin is a combination of direct and indirect. Normal rules out any significant impairment of the excretory function of the liver or hemolysis. Marked increase with significant decrease in hemoglobin and increase in reticulocytes, reticulocytosis. Reticulocytes are immature red blood cells, strongly suggest massive hemorrhage. Elevated serum bilirubin is going to lead to jaundice. Increased direct bilirubin is obstructive jaundice. Increased indirect bilirubin and drop in hemoglobin reticulocytosis means massive hemolysis. Prothrombin time and partial thromboplastin time. Prothrombin is made in the liver and will decrease with hepatocellular disease. Prothrombin time, the clotting time, will increase with hepatocellular disease. We check these labs prior to a paracentesis to ensure that the patient will not bleed out. You have made it to the end.